Good morning, good afternoon, or good evening to everyone. From wherever you are, welcome to the HDC webinar of December. Today's session will present the work of the UN Interagency Group on Child Mortality Estimation, which is a consortium of partners specialized in health statistics, demography, and epidemiology, and how they work with the Child and Adolescent Cause of Death Estimation Group, which provides estimates for cause of death for young populations. So this webinar will outline the process of their work together, and it includes an explanation of the data sources and models used to produce the estimates. At the end of the presentations, we'll have an interactive Q&A. And our guest speakers today are Dr. Kathleen Strong. She's scientist in the Child Health and Development Unit of the Department of Maternal, Child, Adolescent Health and Aging at WHO headquarters in Geneva, Switzerland. We also have Dr. Danton Yu. She's demographer and chief of demographics and senior advisor for statistics and monitoring in the Division of Data Analytics Planning and Monitoring at UNICEF New York. We have Dr. Li Liu. She's associate professor in the departments of population, family and reproductive health, and international health at the Johns Hopkins Bloomberg School of Public Health. And last but not least, we have Francisco Villavicencio. He's senior researcher at University of Barcelona, and he's an associate at the Johns Hopkins Bloomberg School of Public Health, and he's been working with the group for 5 years. So before we start, please note that this webinar is being recorded, and I would like to make this recording available via our HDC YouTube channel for those who could not join us today. I will now give the floor to Kate, who has kindly agreed to facilitate this session. Kate, over to you.
Okay, so I'll need to share my screen. There we go. Now I can do that. And I will do this. I hope that you can all see this. I will just get this situated here so that you can see me and the screen at the same time. All right, so thank you very much for joining us today. And we have a great and interactive presentation with some display about the data on the data portal for the final.
Sorry, Kate, I think we see the presenter view and also your reminders as well.
Oh, wow, that's pretty exciting. Let's try this again. Okay. Let's do it this way. How's this?
Great. It's perfect.
Now we're seeing the big slide. Okay, great. Yeah. So we're going to talk today about working together to improve child, adolescent, and young adult mortality estimation. What we're going to do is really bring together the rationale for doing this, and then the groups that are really working together through the UN interagencies and many academic groups as well come together, and we do this work, and we work with countries to provide the data and the information to get the best possible estimates for child mortality, child, adolescent, and young adult mortality. And the global context for this is pretty obvious in a lot of ways. So we have the Sustainable Development Goals, we have WHO, UNICEF, and other organizations, global programs of work. SDG has really driven us to look at equity and universal health coverage. And we have some set targets that countries are working towards for 2030. Those are SDG targets 3.2, 3.2.1, and 3.2.2. So 3.2.2 is to reduce neonatal mortality to at least as low as 12 deaths per 1,000 live births. And 3.2.1 is to reduce under 5 mortality to at least as low as 25 deaths per 1,000 live births. And we know right now that for a lot of countries, these are really difficult goals to achieve. We have 54 countries that are not on track to meet the under 5 mortality target by 2030, and 63 that are not on track to meet the neonatal mortality target. And so we have a lot of initiatives that are working in this space to really try to help countries to provide the technical assistance needed to meet these survival goals. There's the Every Newborn Action Plan. There's a global strategy for women, children, and adolescent health. And that has a pretty strong focus on survive, but also thrive and transform. And then the Child Survival Action Initiative as well, that's trying to make some progress here. So what are the key inputs to this work? Well, estimating all-cause mortality and then cause-specific mortality really helps to orient national programs and policies to support these child, adolescent, and young adult survival goals. And it really is good to have targets and to know how you're progressing or have some sort of idea about that. So that's the rationale for this. And we have been doing this for a considerable amount of time. It's not a new process. So we have developed over the years the knowledge, skills, and technology to take this work forward. Starting with back in the 1980s and 1990s with the survey instruments that were collecting a lot of this information from countries, the DHS, the mix, and then bringing this together was what was then known in 2001 as the CHIRG, the Child Health Epidemiology Reference Group, which then became the Maternal and Child Health Epidemiology Estimation Group, and is now known as the Child and Adolescent Cause of Death Estimation Group. So we've had a transformation in name, but the actual product and process has remained very much the same. And of course, in 2004, the interagencies come together to do child mortality estimation, starting with the under 5 and now moving up into the young adults as well. So these groups have been in collaboration for a number of years. And we look at first the all-cause mortality. The interagency group on child mortality estimation is really looking at the all-cause, what we call the envelopes. How many children, adolescents, and adults die each year, young adults die each year by country, region, regional grouping, and in the world. So really disaggregating that from the newborns, the first 28 days of life, the 1 to 59 month period, the post-neonatal under 5 period, under 5, combining both of those, 5 to 9, 10 to 14, 15 to 19, and now 20 to 24 years. And this group is UNICEF, WHO, the World Bank Group, UNDESA Population Division, with a number of technical advisors who are experts in demography, epidemiology, and health statistics. We hold regular meetings, there are annual country consultations on the numbers, and annual reporting. Back before the COVID period, there were workshops to build an analytical capacity in countries and to really explain the methods and to improve the data collections and the use of the data. Moving on to the child and adolescent cause of death group. So as I said, has been known under different names, CHIRG, MICI, and now CA code. It's also represented by a number of academic institutions, WHO, UNICEF, and UNDESA Pop Division, and looking at the specific causes for mortality in children and adolescents under the ages of 20 years. And there are very specific causes for these age groups. And so they reflect causes that are at least 3% of the total for the age group in question. The group has annual meetings with technical units and WHO, UNAIDS, and other key data holders and users, and is now, as we're going to update you today, presenting estimates on the UN IGME website. So we're really connecting the all-cause mortality with the cause-specific mortality now in one place for complete transparency and ease of use. So this has resulted in a number of products that are available and also available on the UN IGME website at childmortality.org. You can see those. WHO really supports the groups with the country consultations. That involves a memo that goes out from the DG to member states requesting the nomination of a focal point. And now we have this online country portal, which the focal points log into and see all of their data. They make comments, they add new sources of data, they have discussions with us, and we can help drive the production of better data and use of country-specific data. The WHO also holds and updates the predictor database for the analysis done for the cause-specific mortality, and those are things like GDP, World Bank Income Group, anything that could help us with the estimation for specific causes of death. And we also support the convening of technical units, regional advisors, and other data providers to actually bring more data into this process to support the validity of the estimates and the improvements of the estimates over time. So after that brief introduction, I really want to hand over to my colleagues. My colleague first, Danson Yu, representing the UN IGME. Danson's from UNICEF, and this is her first slide. Danson?
Thank you, Kate. Yeah, so I'm Danson Yu from UNICEF. I'm going to talk about the UN IGME's work. Kate already discussed a little bit regarding the work scope of UN IGME. I'll provide more information on this. Next slide. So Kate already mentioned this, and I won't repeat, but just really to highlight that there are a lot of global and regional initiatives, and all this recognize the urgent need to prevent child deaths, and has set targets to monitor the progress. Next. So regarding the UN IGME, it was formed in 2004. So I just want to mention that we have been working on more than a decade, almost 2 decades for the mortality estimation work. And it has a technical advisory group, which provide advice and recommendations for the technical work of the group. Next. So in addition to the estimation work Kate mentioned, for the age from age 0 to 24, including all children, adolescents, and youth, for all cause mortality, and we also work on the methodological development. And also to provide support to countries to strengthen data system in countries, and also build capacity and strengthen capacity at a local level. Next. Just very quickly to mention the UN IGME's estimation process. First, we compile data and also processing the data to conduct data quality assessment, and if needed, adjust the raw data, etc. And then we do the modeling work, use a statistical model, and then we do some extrapolation just to fill the gaps when we do not have the data available, the input data available for recent years. Then it's the production of the publications and etc. And also during the course we conduct a country consultation, provide countries the opportunities to provide data, new data available, or provide us feedback. So it really engage country government agencies into this process. Next. So this is the typical timeline in recent years. Before we published the UN IGME estimates in September, but due to COVID-19, more assessment work needs to be done, and the country consultation also needs more time. So we changed the cycle. to publish, either in the end of the year or early of the next year. So this is the current timeline, and we may switch back in the near future not to publish in September or October. Next. Very quickly regarding the underlying data sources we use for the modeling work. So we compile data from various data sources, including vital registration systems, sample registration systems, and also population census and household surveys. And indeed, I forgot to say the group also work on the stillbirth estimation work. So for stillbirth estimation work, we also use some case studies for child mortality indicators. For ages 0 to 24. We usually don't use subnational data, but for stillbirth, due to very limited data availability, we may also use subnational data, considering the coverage, etc. Yeah, and those data, of course, have a lot of data errors. In some cases, like omission of deaths. And for household surveys, for example, we have sampling errors, etc. So we usually need to conduct data quality assessment first before we can include as input data for the modeling work. Next. Yeah, so this slide just show a few examples, for the underlying data, which is the nationally representative data from countries. Either from household surveys or census, etc. But for low and middle income countries, usually the majority of the data from household surveys. And you can see the first example is a good example to show consistency across different data sources. But the second example on the top really show large variation across the data sources. So in this case, data quality assessment is really needed to see which survey has more reliable data and high quality, and which are not. Yeah, and then we also see some example here. For example, the first one at the bottom. The vital registration data is quite low, which is at the bottom, the black square, comparing to other data sources. And this is very common in some of the middle income countries, like in Latin America, etc. So we also needed to assess the quality. Next. So we have been asked, all the time, why we use a model to derive child mortality estimates instead of just use the face value from a report from the household survey, for example. And I think the example I have showed you already indicate one reason. There are a lot of inconsistencies sometimes across data sources. And given sampling errors, etc., it is not always quite robust to just use one survey. So the first one, as I said, is lack of a single source over a long time period. And sometimes we also cannot compare one source to another. So we need to do something to generate more robust estimates, and data quality issues, of course, and other reason. And the other things are the other factors we consider is the ample data, usually also not very timely. From household survey, for example, the most recent data points refer to a 5-year period prior to the survey. So there's a time lag, and we do our best not to use the optimized interval to calculate data from household surveys, and also do the extrapolation to really fill the gaps. And the consistent trend line also and estimates are needed for comparison reasons across countries. So standard methodology is needed for these purposes. Next. I want to go to details for all the models, the methodology part, which require a lot of time. But all the information is available in the UN IGME web portal, childmortality.org. In the methods section, you will find many journal articles, etc. So if you are interested, can go there and look into it. But just very simply to say, we use a statistical model to account for data errors and also generate a smoother trend line. But we also add a crisis mortality. We adjust, for disaster mortality, for conflict, deaths for conflicts, etc. So there are also a lot of adjustment for HIV/AIDS as well. In some of the high prevalence countries, etc. So those are additional points just want to make here. Yeah, next. So now I will show some results regarding the latest UN IGME findings. Next. So in the world, we still have over 5 million children under age 5 died in 2021 alone. This is the latest estimates, and in February next year, we are going to publish the estimates for the year 2022. And you can see that the distribution of the deaths across the age groups here. And definitely under 5, account for the majority of the deaths from age 0 to 24. Next slide. And this slide shows the under 5 mortality rates across different age groups, and also the number of deaths. And we can see for the old age groups, the rates are lower, and under 5 is the highest. Next. From the previous chart, we already see a decline trend. Indeed, all age groups we see that the decline in the rates and also deaths. But no, we are very happy to see also in 88 countries, including 39 low and middle income countries, they cut their under 5 mortality rate by at least 2/3 since 1990. So this chart shows the under 5 mortality rate in 2021, and also the percentage decline in under 5 mortality rate, which is on the y-axis. And we also classified by income group using the color, and the bubble size is proportional to the under 5 deaths. So you can see, there are a lot of low-income countries, as well the orange ones above the 2/3 reduction here. Yeah, and the green as well for low and middle income. Yeah, so that's good news. Progress is possible even in those countries. Next. And this one shows the probability of dying for 5-year age groups among children and youth by different regions. And we can see Sub-Saharan Africa is among the among the is the highest, has the highest mortality rates across all age groups. Next. One maybe not good news is that progress in reducing mortality accelerated among children under age 5 after 2000. In thousands, but slowed down in the last decade. So it's not good now. We have acceleration before, but now we slowed it down. Yes, it may be some, and one reason maybe when mortality rate is high, it's easy to be reduced. But currently, many countries, particularly in Sub-Saharan Africa and South Asia, their mortality rates are still very high. So the decline of the speed should not slowing down. But now we have slowed down. So that's a warning for the global community and for countries. We needed to do more to prevent child deaths. Next. I will skip this one quickly just to say the 5 to 9 age groups, they have the fastest progress, except if among the children and youth over age 5. Under 5 has the fastest usually, but among the old ages 5 to 9 years, they have the fastest progress. Next. And this is well known. We know that Sub-Saharan Africa and South Asia, they have highest mortality rates. So from the charts, you really can see the dark color usually shows higher mortality rates. Very clear message from the maps here. Next. And of course, we need subnational mortality rates to understand where we should focus on geographically. And because national estimates usually mask the discrepancies across regions, etc. So the UN IGME also produces subnational estimates. Now this is the second round publication, and we produced the subnational estimates for 31 countries at the administrative 1 level, and 24 countries at administrative 2 level. Next slide. And this chart just to show us the large discrepancies within the same country across the regions. So you can see for Nigeria on the top, for example, there are many circles there, which from less than maybe 40 to over 250. So this is the range of under 5 mortality rates for Nigeria across the regions. There's a large differences here, and other countries also similar. You can see there. Next slide. And the other thing I want to highlight is the increasing share of neonatal deaths among under 5 deaths, increased from 40% to now almost half of under 5 deaths, 47% now in 2021. Next slide. And we also generate estimates by wealth quintile, by sex, etc. And so here is just to show the results for under 5 mortality rate by wealth quintile. And then you can see here a clear message, we have large discrepancies by Wales quintile in all the 5 mortality rates. And interestingly, the absolute differences across the Wales quintiles has been narrowed, but not the relative differences, which means in terms of percentage difference, it didn't change, has not been changed. So this is still concerning for the poorest, and we need to do more work. Next slide. And Kate already mentioned 54 countries need to accelerate progress to reach the under 5 mortality SDG target by the year 2030. And for neonatal mortality rate, it is 33 countries. So you can see here those orange or red, those countries, they need to accelerate progress in order to meet the SDG targets. And mainly these countries are in Sub-Saharan Africa and also South Asia. Yeah. Next slide. Also, we looked into how many deaths would occur if current trends continue. So this number is nearly 59 million children, adolescents, and young people under the age of 25 will die between 2022 and 2030. So this is a large number, and we must to do something to prevent it. Next slide. We also kind of look into the different scenarios to see how many lives we could save if we do things differently, if we bend the curves. So if we are able to achieve the SDG target, and we could save 10 million of children under the age of 5 in the next 8 years by 2030. So this is also a big number, and we must really act urgently to meet the SDG target. And if we are able to meet the average mortality rate of high-income countries, then we would save more lives. Yeah, that's the blue part, the dark blue part highlighted here. Next slide. So very quickly, high-level summary. Substantial progress has been made in reducing child mortality across all age groups, but still too many children die each year, and large disparities exist across and within countries. And acceleration is urgently needed to achieve SDG targets and to save lives of newborns and children. Next slide. Just to show very quickly our data portal, childmortality.org. This portal has all the relevant underlying data, estimates, methodology, publications, for all-cause mortality for many years already. But as Kate mentioned, we know this year we also incorporated the CA code's cause-specific mortality into this data portal, so you can find more information on cause of death now on this site. And I'm sure Lee and Pentro will talk more about this, so I won't cover that area. I think the next slide, I may have one more slide. Yeah, just to show you some illustration from the website. We have country profiles as well for different age groups. And we also show you, all the underlying data available and to derive the IGME trend lines and along with the uncertainty ranges, etc. So you can find all the very detailed information on this site. Yeah, I think that's the last slide. Yeah. Hand over to Lee, talk about the cause-specific mortality.
Thanks, Danjin. Thanks, Kate. Hello, everyone. let me just share, if you can stop.
Yeah, I'm trying to stop sharing. Sorry, I've gotten a little bit lost here.
Yeah, I guess
see.
the share screen. Okay.
Where's the share screen? Let me click.
Yeah, the button can be mysterious sometimes.
Yeah, it is kind of, here we go. Now I found it. Don't worry. Let me stop. Okay.
Perfect. Thank you so much. So here's my Google slide deck, and let me just do the, can you see my screen? Let me actually make it full screen. Here we go. Looking good?
Yes.
Yep.
Perfect. Okay. Thanks, everyone. So, yes, I'll be talking about estimating global, regional, and national cause of death among children and adolescents, representing the CA code, or the Child and Adolescent Cause of Death Estimation project here. I'm the co-PI on the project with Bob Black. And I think, this presentation for me will be a very high level introduction. And, Pancho, who's part of our team, will be talking about more about the new and fresh CA code data portal as part of the CME, the childmortality.org site, momentarily, to walk you through some of the additional results. But the idea here is to give you a flavor of what we've been doing, and hopefully, if you're interested to know more, you can either visit the site, or maybe look up some of our publications for additional details. So I think Kate mentioned, or give a snapshot of the evolution of the project and the group who has been working on this. In fact, I think it started actually, early 2000s, a group of, folks who are really dedicated to, improve estimates of cause of death have been coming together. But I think, the group has formally formed, starting from 2008 as a Child Health Epidemiology Reference Group, the CHIRC group. And for the next 5 years, because there has been funding supporting the activities, and, there has been annual meetings coming together to try to provide, peer review. And we still actually, till this day, benefit from the infrastructures that, the early, CHIRC members have actually established. But then the project or the activities have actually gone through a few different iterations. So between 2013 and 2018, we are part of this maternal and child epidemiology estimation project. And actually between 2017 and 2023, we're folded into this larger IMPROVE grant to try to improve, child survival in general. And, come to 2022, we are in our current form, which is, very much focused on child and adolescent cause of death estimation. So I'll just be talking a bit more about that particular project here. The CA Code project actually has 5 distinctive yet complementary objectives. Of course, they're all surrounding and supporting and trying to achieve this overarching goal of improving cause of death estimation for both children and adolescents. However, specifically, we are here to actually work on the 5 objectives. The first one is this methodological innovation, where we are to actually harness emerging empirical data and cutting edge methodological innovations to produce a couple of new rounds of CA code estimates. And the second piece is really a new piece that has been added to this particular round of grant or activities. We are becoming a lot more intentional to try to actually engage with countries, specifically to try to engage countries for CA code data generation and curation, and also CA code estimation, integration, and utilization. So, for folks in the audience who are country representatives, I think I've seen a couple who may be, if you have any, either all cause or cause specific technical assistance needs or questions, we're definitely your resources. I'm very happy to, engage in further conversations about how we can actually come together to collaborate and maybe help you achieve some of the child survival related goals. And the other thing I want to mention is, this today is part of our country engagement activities. We're trying to, do more dissemination. We're trying to actually, participate in dialogues to hopefully, better disseminate, but also better engage with the community. The third objective is also an objective that embodies what we're doing today, which is harmonization and synchronization, specifically to enhance harmonization and synchronization of global, regional, and national estimation and estimates of child and adolescent mortality, that is all cause, and cause of death, which is specifically what we do here in CA Code. And the fourth objective here is a super interesting objective, which is a primary data collection piece where we are to compare cause of death estimates for deaths occurred in facilities versus communities by utilizing medically certified cause of death here. And the reason that's interesting is because we have a lot more data coming from, cause of death data specifically coming from facilities, less so coming from communities that are representative. So this particular research objective is, trying to actually understand to what extent or under what circumstances we can utilize those facility-based data to either, inform or actually enhance the policy making and evidence generation process to support child survival policies and programs. And lastly, we have this results dissemination objective, which is really to try to improve global access and visibility and impacts and utilization of our estimates. And again, I think this is also today's activity, and our webinar is also part of that, that to achieve that goal or objective as well. With that, let me actually walk you through this data gap map a bit more. I think Denjin has actually both Denjin and Kate actually really laid out the data gap already, but this actually diving a bit deeper into the cost specific space. So the data is a little outdated, so maybe some decimal places needs to be changed, but the message is the same. So basically, we have a lot of data in countries where very little under-5 deaths occurred. So, for example, these are countries where adequate vital registration systems are available, mostly represented by the sort of, light yellow / salmon color countries, mostly high income or some high middle income countries fall in this category. However, majority of under 5 death, of course, I'm using under 5 death as an example, situations are very similar for other age groups. 90% of under 5 deaths actually occurred in countries with very little data. And those countries are represented by the neon green color here. And for those countries, at best, we probably have verbal autopsy studies, and I'll talk a bit more about what they are for those of you who are not familiar with that. But then, for those countries, VAs are not, always available. They have quality issues that we need to deal with. So instead, we actually use statistical models to produce estimates for that. So I think, Denjin mentioned some of the reasons why IGME actually used models to model estimates. So we essentially are faced with similar situations and make similar choices in terms of, going to statistical models to take account of data scarcity, but also, data quality issues and uncertainties with cause of death estimates. So moving a bit more into the estimation framework here. So we do start from the envelopes that IGME has been producing, and again taking under 5 as an example here, and the 5 to 19 estimates we produce. The process is by and large similar. So we first take the neonatal and 1 to 59 months deaths, a total number of death, all-cause death as the envelopes, and we actually produce this pie chart, or this pie, which is essentially to estimate cause-specific mortality fractions for countries and years. So to do that, we produce the estimates depending on the data availability and quality. So for those countries where I showed earlier, with the light yellow color, countries with high quality vital registration system, we use their data as is or with minor adjustments, for example, to redistribute garbage codes. And then the next box here are countries where they have low mortality. However, they do not have very high quality VR data, and sometimes their data are problematic. So for those countries, we use VR data from the first box, and feed into this model and produce estimates through statistical model for them to correct, the data issues. And then majority of the countries actually fall in this sort of, red box here, which are countries that have some form of VA data at best. And, for those countries, we actually use this multi-cause model and utilize their relationship between cause of death and a suite of covariates. And I'll talk a bit more about that in the next slide. So that relationship, we assume, is generalizable to country years that are outside of the study input data. And based on that particular relationship, we then, predict for country years to produce our cause of death estimates. We do have some additional scenarios or situations, for India and China, where, established sample registration systems have been operating for years, or actually, in this case, sometimes decades. We do have sufficient data to, produce empirical estimates, and actually at this, in this particular case, at the subnational level. So both national and subnational level as well. So for India, we use the subnational multi-cause model, and for China, we just empirically adjusted their maternal and child health surveillance system data, to consider the complex, survey design, sampling survey design. And lastly, we also have single cause estimates coming in, and these are causes with relatively low burden of mortality, or a smaller share, very small share actually, of the total number of deaths. And it's really challenging for the model to estimate for them because they're so small. So instead, we actually rely on WHO and UN single cause programs to actually produce those estimates, and we fit into the entire global pie and the national pie for each country years. I'll talk a bit more about what they are in the next slide. So here are some of the additional information on the input data. To feed into our multi-cause models by different data sources, we actually have a very rigorous procurement process for both input study data, including both the cause of death, which is the left-hand side of the regression, and the covariates, which are the right-hand side of the regression. So for cause of death data procurement, we actually have this really careful process to curate data, and this is also part of the, I think, steps where we probably are somewhat different from, for example, the GBD process, the global burden of disease process. So one major part of the contributing source is through a systematic review. This is conducted periodically for each major round of updates to identify new literature published on cause of death, and through that we extract relevant information to feed into the model. And this process is systematically managed by this distiller program, and in distiller, in the recent years, they have also included artificial intelligence to enhance the efficiency of this entire systematic review process. But in addition to the published or peer-reviewed literature, we also have this really important investigator tracing process. So we, come to know investigators have been conducting cause of death, studies. We contact those investigators, and we try to also procure those cause of death data as well. So one such example is the recent countrywide mortality surveillance for action, or the COMSA project. So this is a project where a sample registration system have been set up in actually so far 2 countries, Sierra Leone and Mozambique, to actually periodically collect cause of death data. And those countries have actually produced about, a few years of data already to this point. Another such example is the Child Health and Mortality Prevention Surveillance, or the CHAMPS project. So this particular project is actually based on 5 or 6 and actually expanding probably up to 10 health and demographic surveillance sites, where really set rigorous and a systematic approach to ascertain cause of death have been applied. In addition, they also are enhanced, at least a part of the cause of death data they collected are enhanced by the innovative minimally invasive tissue sampling technique, or the MITS technique. So that part, that technique, CHAMPS plus MITS, have been actually considered as, I'm reluctant to say gold standard, but like a good reference standard to actually compare with some of the verbal autopsy studies. And here probably is a good chance for me to explain a bit more about what verbal autopsy studies are. So these are studies where, a tool, like a survey-like tool, have been deployed to collect information from the caregivers on signs and symptoms surrounding the event of death, sometimes actually including care seeking as well. And based on this information, people use, cause ascertaining methods, including physician reviews and computer-based algorithms to try to ascertain cause of death. So, based on my very, brief description, can probably already infer that, the VA is not a particularly, accurate tool to arrive at cause of death. Especially in comparison to the gold standard of medically certified cause of death. So there are a lot more, I think work needs to be done to understand the differences, but also at the same time, in low and middle income countries, we do not have the capacity to medically certify every single death. And actually the gap is really large. So how do we go from, sporadic VA studies to, systematic, medical certification of cause of death, and hopefully integration into the civil registration and vital statistics system is a big question. Okay, coming back to today, and we can discuss that, in the discussions, if of interest. But coming back to this data source here. So basically, we try to get to as much, cause of death data as possible, and we try to get to high quality data as well. For the cause of death, and then move on to the right hand side of the regression. We do have a suite of covariates, and those are largely driven by the the Mosley and Chen conceptual framework of child survival, for those of you who have been in the field for a while, and essentially the approximate and distal determinants of child survival. And here we have, for example, social economic characteristics, and as well as child survival interventions such as vaccines to be included in the right hand side of the regression. And lastly, going to zooming into the single causes, which I mentioned earlier, why we have separate source of estimation processes for them. So these are HIV, measles, malaria, TB, and crisis, and most of them are really low burden causes, and some of them are epidemic causes such as measles, where things goes up and down actually quite drastically. So really hard to sort of model in a sort of a averaging sort of a philosophy type of model. Okay, with that, let me move on to the data quality issue just a little bit to give you a sense of, what we're dealing, one of the issues really, one of a gazillion issues we're dealing with. So what I'm showing here is, a bar chart of a number of different in-depth the health and demographic surveillance sites where they have been routinely collect cause of death data. And these are for 5 to 14-year-old. So what you can see is that, there are a bunch of different causes available. However, I want to draw your attention to this, gray bar to the right of each figure here. So that actually represents the indeterminate cause. I also want to mention that these are coming from in-depth and probably from the iShare2 website. And we probably, got those data, quite a few years back. So these needs to be updated, but the idea is still the same, where in-depth sites actually use VA, verbal autopsy studies, but then they use the inter-VA, which is one particular computer-based algorithm to try to ascertain cause of death. And the inter-VA is usually, it generates pretty high indeterminate fractions, as you can see from that, dark gray bar, to the right of each figure. So one inclusion criteria we have, so, in the systematic review process, for those of you who are familiar with that, you set up, a set of predefined inclusion and exclusion criteria. So one of the inclusion criteria for quality concerns is the indeterminate causes have to be at maximum 25% of the total number of deaths, right? So if you apply that particular criteria out of this many, so we have 18 sites or 18 sites here. Out of 18 sites, we only have about 6 sites or 7 sites. Did I do my math correctly? We have a large, fraction of the sites that we cannot use anymore because the cause of death, based on InterVA, give indeterminate fraction that's actually greater than 25%. So this is one of the issues we're dealing with, when it comes to VA studies. I think there is a quick maybe question in the Q&A. Can you explain the difference between other infections, other causes, and external causes? Okay, so I don't know the ICD codes to those, off the top of my head. I think, these are just residual, actually. Yeah, so other infections would probably be infections other than pneumonia and malaria and HIV, and external causes.
So okay. I think it depends on the age group involved. Right, so we have documentation.
So these are 5 to 14 here, exactly.
So for the question asked, we just need to clarify which age. Oh, I see.
Right.
Yeah. Okay.
Yeah. Right. Yeah. And external causes usually refer to all sorts of different injuries. And I think in this case, other causes are everything else that's not mentioned or grouped into the existing causes. But if you're interested, we can probably dig up the ICD grouping for these and share that. If you can give us your email. Okay, thank you. And let me actually move on, and we can further discuss this in the discussion or Q&A session. Sorry, am I back to this? Okay, right. So before give a quick review of the results for 2021, I just want to say a little bit more about the modeling process. So what we have been using in the last two rounds of estimation now is this multinomial regression innovation framework. Specifically for covariance selection, we actually have been using this Lasso approach, which is least absolute shrinkage and selection operator. So this particular approach actually is such that you don't have to make subjective decisions on which covariate to include or to exclude. All covariates can be included, but they actually assign different weights or different importance to different covariates based on the data. The other thing that we added, since 2 rounds ago was we are trying to actually give more influence and more weights to countries where nationally representative studies are available, and those are rare. So actually, there are probably a handful, excuse me, now maybe about 24 or so actually countries or country years of nationally representative VA studies that have become available already. But still, I mean, in the in the entire sort of space that we're trying to estimate, those are a drop of water in a bucket. So, but what we did for those countries are, we try to use this random effects in the Bayesian framework to try to give those countries more weights so that they have more influence over, a bit more influence over the results. You have to be, make sure that the balance is, right. And last but not least, we have started to actually apply misclassification matrix 2 rounds ago and continue to work on that. So what that means is I mentioned a bit more about the biases and measurement errors associated with verbal autopsy as a tool to measure cause of death. And basically, this misclassification matrix is a tool to take into account those measurement errors associated with VA and systematically incorporate that into the modeling process. As the CHAMPs and the MITs become a lot more available, additional statistical work have been happening to understand how much variation there is around different cause ascertaining methods, depending around by different countries. And so we are also trying to incorporate those line of work. And actually, one of such researchers is Abidata at Hopkins, who's a statistician or biostatistician in our school, has been leading this work, and we're trying to essentially incorporate, the work he and his team have been actually developing in this area, and super exciting. I wish we can talk to you about that in the future. So let me just, dive into the results here. I'm showing two global pies. One to the left is the under 5, and one to the right is the 5 to 19. And these are two pies for year 2021. So as you can probably quickly glance, the leading causes for under 5 more or less stay the same: prematurity at 18.1%, lower respiratory infections or pneumonia at 14.2%, and birth asphyxia or intrapartum related events at 11.5%. And for 5 to 19, we have a lot more sort of, other causes category, because, you do have a lot more causes actually you need to consider here. However, for those specific causes, we can see, for example, road traffic injury is the leading cause at 7.9%, cancer at 7%, and malaria at 6.1%. So these are some of the leading causes in 2021. If we sort of zoom into some global trend, so this is a snapshot of our exciting CA-code data portal, which Pancho will be talking about momentarily to give you some demonstrations. So what I'm showing here is the top 3 leading causes for under 5. Again, prematurity, low respiratory infections, and birth asphyxia. So similar to what Danjen has shown for under 5, we do see faster declines up until, for some causes, maybe 2010 actually, for some other causes, 2015. But then there's this, slower trend happening since 2015. So definitely, continued focus on child survival programs is warranted. Additional details of the results and access to the data portal, for example, is included in this Lancet Global Health paper that Pancho has led for our group. And just give you a quick snapshot of the new data portal. So here we have the cause of death now listed as a separate tab from the all-cause mortality that Danjen showed earlier. We also have this, banner or news feed listed as the top of the updates, since, we just actually released this at the end of October. So everything is still hot and fresh. I think that's it for me. So I don't think there's any new questions. Maybe over to you, Pancho, to show us the CA-code data portal a bit more.
Okay, thank you, Lee. Thank you all. I'm Pancho or Francisco, whatever you prefer. I'm very happy to be here to talk about the new upgrade of the UN IGME Child Mortality data portal. So I'm going to go through the data portal to show you some of the main aspects. So I'm going to share the link so you're welcome to browse at the same time with childmortality.org. And well, this is the result of a joint project between between CA-code project, UNICEF, UN IGME, WHO, and we are all from the CA-code. As a CA-code representative, we are really thankful to all the partners for the work that we're doing together. So as Lee mentioned it, so those who perhaps of you were already familiar with child mortality, previously what it used to have is only all-cause mortality. That means the estimates on mortality estimates produced by UN IGME that do not have like a cause-specific resolution. What has been incorporated now is this new section that is cause of death with all the causes of death estimates that are produced by the CA-code project. So let me go, here is the homepage, which is practically the same as it used to be. So only that here we have this direct link to cause of death, and you scroll down, then you can have some estimates and source data on mortality. And finally, at the very bottom, the main publications, both from UN IGME and both from CA Code, that are available. So these are highlighting the most important publications. And here on the left side, we have these updates or news. And as Lee mentioned, so the launch of the data portal in October came together with the publication of a comment in Lancet Global Health that you can, by clicking here, you can access to this publication that I think was yesterday or today or 2 days ago, that was finally assigned to a journal, to an issue, sorry. Okay, so I'm going to skip the all-cause mortalities. This is the UN IGME part. That is how it was already there before this new upgrade. So let me go to cause of death. That is where the CA Code project has contributed more. So here mainly we have 3 indicators. So the CA Code, traditionally, CA Code has been producing estimates on death counts, fractions, which this refers to percents, that sum up to 100%, and then rates, mortality rates. So the user mainly can choose which indicator they want to check. Then we can select the age group, neonatal, 1 to 59 months, under 5, which is the aggregation of the previous 2, 5 to 9, 10 to 14, and 15 to 19. In general, for all the age groups, estimates are for both sexes combined, except for 15 to 19. In the case of 15 to 19, we can select whether we want to have female or male data. And by changing the selection, of course, the cause of death vary. And then if we scroll down, we can have all the cause of death that for which a CA Code produces estimates. And important aspects here, one is that depending on which age group the user selects, the causes of death are available. No? For example, if we see here maternal causes, these only refer to 15 to 19 females. So any other age group selected will not allow the user to select maternal causes. Only when we select 15 to 19 and females, then now we can add maternal causes to our chart. And also referring to the previous question that was on the chat about what do these causes refer to, here we have a question mark for users when they do not know or have questions about what do these causes refer to. So by clicking here, we open a new tab that goes to the methods section, in which we have included a table with all the causes that we have report, so 28 in total. They are classified by communicable, non-communicable, and injuries. And then we have the age groups that they apply for each of these causes, a brief description, and finally the ICD-10 codes that apply to these causes. And for example, I think the external causes that was mentioned earlier, so external causes usually is for injuries. And in the case of under 5s, we don't do the split of, we don't split injuries in different categories. So we have injuries as a whole. But if we go to older age groups from 5 onwards, then we have all these disaggregation in drowning, road traffic injuries, self-harm, interpersonal violence, etc. So this table that is in the method section can give you a quick mapping of the label that we use in the portal, the groups, the description, and the causes of death. And then finally, if you want more details about, here we have the main papers in which we describe our methods. Okay, so these are the methods. Let me go back to the data selection. So here, not only we can select the rate, and then here if we go to the point, we have exactly the cause, the point estimate, and in this case 0.7, and the uncertainty interval that here from the CA Code project, we report 95% uncertainty intervals. And then if we go to estimates, quickly estimates, then here we have the estimates not so in a table, and it's very easy to download these estimates, just clicking here, and then we have it's a CSV file that by default it can be opened with Excel. Okay, then here the user can download all the estimates that we have. Okay, so this is for rates. Deaths works pretty much the same. So the user needs to select an age group, and then up to 3 causes that apply to that age group, and then going to chart, we can have these time trends. What is perhaps more interesting in this case, in this part of the data portal, is the fraction, that means the percents, because here the user has more options, okay? One option is, for example, to visualize the proportion, the proportion of HIV deaths in 5 to 9, in under 5 years, or over time, so from 2000 to 2021. But perhaps the user wants to do something different and prefers to select, wants to have compare the HIV fractions for all age groups. Then they can select here HIV, all the age groups, and then what we have is for those, and then here we can visualize the fractions of HIV deaths for the different age groups. Here, 15 to 19 is missing because of the sex split. This is something we still need to solve, but in theory, also we also have 15 to 19 HIV estimates. And by selecting the year, we can see the fractions of different years. So this is 2021, but the user can, for example, try to see 2009, and then they will see different fractions. And then here again, if we go into the bar, we can have the point estimate 0.056% and the corresponding uncertainty interval. Okay, this is the main part where we can have these estimates, but then we can go here to compare estimates. Here there's more flexibility because there's not a limit of 3 causes that we can see, and then we can compare different countries and then different variables, so there's more flexibility, so the user can select what they want to visualize. I think there's a question. Should I go now? Yeah, that's a good point. Okay, you want to answer, Lee? Please go ahead.
Yeah, sorry, I wasn't sure. I thought I could just type in the answer or something, but I guess answer live meant I have to go off mute. Yeah, I was just gonna say that we appreciate your comment about that, and we actually, understand the situation is not only starting from 15. However, as I mentioned, that there are many causes in the 5 to 19 category, and actually very little data. So what I showed for under 5 is a much better situation compared to 5 to 19. So we have this constant struggle between, how many causes we can feasibly estimate versus how much data that can actually allow us to estimate. And I think for the 2 rounds we have been estimating 5 to 19, the decision we made is, I think we have this cutoff of 3% of the global burden for that particular age group. I think for maternal mortality, it's probably not gonna, actually based on the current data we have, it's not gonna, it didn't make that cutoff. Therefore, we didn't estimate for 10 to 14 for that particular cause. I don't know whether, Pancho, you're actually the one who has done this. I don't know whether you have anything to add.
Yeah, you're completely right. So the problem is that the data we have for 10 to 14, well, there's another additional point is that we don't do the sex split from 10 to 14. So
yeah, that's another thing. Yes.
So we have both sexes combined. Then in this case, the percent of the maternal deaths is really low, and in addition, it was very hard to obtain data, at least in the data we have for reporting maternal deaths for these age groups. So at the end, the decision was to only report maternal deaths starting at age 15. That is the age in which we do the sex split. Oh, I see there are more questions. Okay. Subnational information, not for causes of death at this point.
But that might be for dancing.
Okay. Okay.
It is on the dancing. It is on the childmortality.org.
Yeah, on the all cause there is some national information.
For all cause.
Yes, for all cause, yes, but for causes specific, we still do not publish causes of death at subnational level.
Well, can I just jump in to say, We did publish them. They're available in peer-reviewed publications format. They're yet to be incorporated into the C-code portal. I mean, if that's something of great interest, we can definitely start to look into a feasibility of including them there. But I think, the difference between what we do and what Dungeon and the IGME group has been doing for the subnational estimation is, for cause of death, you only have a small number of countries that could actually afford to have subnational estimation because, there are sufficient number of, data points to do that. Whereas I think, Dungeon is probably, in this case, in relative terms, a bit more wealthier than us. I don't know, Dungeon, you want to add anything to that?
No, just to say for the subnational estimates, we also uploaded in the portal. If you click a country, if the subnational estimates icon is maybe you can select, a country has like I forgot.
For example,
one Africa country, like I think we have for Rwanda probably. Uganda, Rwanda.
Yeah, here subnational.
No, it's not available. Rwanda, and how about Rwanda?
Yeah, Uganda. Rwanda.
Rwanda, yeah, no Uganda.
No, but Uganda too, no? I think. What I see from the map or not?
Oh yeah, okay, yeah. Subnational is available. Yeah.
Yeah.
And then you can select the admin level above the map.
So go above.
And above the map, there's a icon.
Okay, here.
No,
okay.
Yeah.
I can go above that as well.
Then you also can, above that, you can see admin 1, admin 2. Yeah.
Okay. I can see.
So this is what we have. So it's only for 31 countries at admin 1 level and 24 for admin 2 level. Yes, and so you may not able to click the subnational for some countries because it's not available. But if it's clickable, then it's there.
Okay. Great, thank you. Okay, let me continue with the causes of death, and then we can go for questions. So after compare estimates, that here the selection is more flexible, then we can do the map estimates, that in this case, there is this map in which we can only see a global map of rates, of mortality rates, and then user can select one cause and one age group, okay? And then it's also, this was a feature that was already in the, it has been like adapted from the already existing before this upgrade, so from IGME. And it's also nice that it's possible to see the evolution over time of these different country cause-specific rates. And finally, here in the data and download data and estimates, here the user can select exactly all the data they want to download, just clicking the country or age group of interest, the indicator, different variables, the causes, and then they will download all everything that is available by clicking here on the data download selection. Okay, so this is the cause of death. Then the other 3 tabs, big tabs on the top, they are shared between UN IGME and CA code, the same as the home page. Here in the profiles are the users can visualize it's more like a summary of the estimates. There's no possibility to interact or to choose the different variables. They only can choose the country at the top one, and then the age group. So we have only 4 age groups and the year of interest. And then with respect to the first estimates graphs, these are UN IGME, they already existed. What we have incorporated here from the CA code is this cause of death. So by clicking here, we go go to the bottom, and then here we have like a pie chart of the main causes of death with the corresponding percents, and then the time trends of the main causes for this particular country and age group, and time trends from 2000 to 2021. So this just, of course, the user can still check the data, but the selection is more limited. Next, in the resources tab, we have all the publications. These include reports, tools, and journal articles that both UN IGME and CA Code have been producing in the last decades. And so by clicking there, one can check the PDFs. And finally, in the About section is just a summary of the two age groups and the different partners that are part of this project. Yeah, so I think that's all from my side. We are still planning to do some improvements, like, for example, adding additional age groups, the aggregation of 10 to aggregated groups, 10 to 19 or 5 to 19, to upload video tutorials so users can have a quick view of how the data portal works. So those are small improvements that we will be incorporating in the next few months. So thank you very much. That's all from my side.
Great. Thanks very much. So I see we have no more really open questions, but are there people who would like to speak and ask a question in our last remaining minutes, or put a question into the Q&A or the chat? Please feel free to do that. Maybe we can clarify some issues, or you can make suggestions or comments on the work that you've seen here. Oh, Lee.
Yeah,
Lee,
maybe I'll just...
do you have a question?
No, more like a comment.
Okay.
I want to actually comment a bit more, or maybe more like asking for some additional rationales. So, I think, there's this, interest about subnational that, some of the audience have raised already, and, even advocated for trying to make this for all countries. I think it's, and Denden's response is not an easy task, which I absolutely agree. But I wonder, if we were to make that happen, what does it take, right? I think probably, we need a lot of advocacy, right, to actually understand and to sort of, raise our voice about, how important these are, and so the funders are aware of that. So maybe, I don't know whether is the audience able to speak up, or probably only type in the Q&A. But like, what are some of the rationales for you to need the subnational estimates, right? Do you need it, so, like, are you, maybe the scenario is you're a district manager, you're trying to actually make a decision on allocating resource based on, all cause and cause-specific mortality. Oh, okay. So if, yeah, so, I think understanding why you need them and what, and raise your voice to advocate for, those estimates being produced could absolutely, and we can work together to do that. I think that could actually create more interest, and maybe more interest even for the funders to potentially, fund something like this. So, and by funders, I do not only mean like fund us to do the estimation work. They can also fund more, surveys, or actually, establish more sample registration system, or even actually vital registration systems, actually to, start more continuous data collection to produce subnational estimates.
So yeah, I mean, it would be great to make sure that we provide the resources and support to countries to improve their vital registration processes, right? Because then they'll be able to use their vital registration data to do their own subnational analysis and national analysis, and that is, of course, what we all want for the future. Now, let's see, we have some Q&A. Fatih is asking, projections, are they available on the portal? So I presume, Fatih, that that's is that for all cause? Because I know that Jansen, you have shown the all cause projections, but is that also for cause specific?
For all cause, yes, I think we do not make it, like in the chart, but there, I believe we have the Excel file you can download on the home page for the projections. Yeah. I'll double check, and if we haven't uploaded, we will. But I do believe this year, and from maybe 2 years ago, we also put the projections there with different scenarios. And the country profile, if you go to the country profiles part, there's projections also shown for each country. That the relevant information is in the country profile as well. And then maybe just about subnational estimates, for all cause of mortality, we have been working quite hard in this area in the last like 5 or 6 years to generate to kind of really develop the methodology and generate reliable estimates. It's not an easy task, and for DHS surveys, for example, there's a package has been developed by Professor John Wakefield, who's also the person proposed the methodology for the UN IGME's subnational mortality estimation work. There is a package already developed by him and the team, and you can use the package to generate reliable subnational estimates from DHS. And for our methodology, we pulled together all the household surveys to increase the sample size and also the events of deaths, etc. So the uncertainty ranges will be smaller instead of we get a large uncertainty ranges, which not make the estimates not so reliable. Yeah, so the methodology is more complicated in our estimation process comparing to the single DHS package, and we are also working on trying to develop a methodology, maybe also incorporate administrative data, at a subnational level into the model, but that will take some time because for many Latin American countries, they have used the vital registration system may produce some reasonable estimates for us to use. At a subnational level, the completeness and the coverage may be still not 100%, but may be able to use them in a way. So we are also developing the methodology on that. But it will take time, step by step. Yeah.
Great, thanks. I think we have really reached the end of our time, and I would like to, if there are no other questions, really thank the audience for sticking with us. And we hope that you enjoyed this, and you can always reach out to us if you have questions and comments so we can continue a dialogue with you. So thank you very much, and good end of the year celebrations to all.
Yes, thanks, and happy holidays, everyone.
Thank you.
Thank you. Happy
Bye.
holidays.
Thank you. Happy holidays.
Bye.
Bye.
Bye for now.